All right. Critical care is a bunch of topics kind of we've already covered. I'm not sure if there's many new drugs. Good news, but I'm revisiting some things that might be somewhat challenging. So I thought it was good to, as a whole together, as far as acute care medicine goes. I know some of you probably have no interest in practicing in acute care, but those that do, I think it's worth talking about how we synthesize some of these topics. So anyway, with a critically ill patient, you're looking at a couple different criteria that would maybe define that and how we're going to be treating these patients. So usually looking at some sort of organ system or organ failure in some capacity, or acute changes in organ function that are going to lead somebody to being what we call critically ill, right? They need some sort of advanced level of care. These patients usually have pretty hefty drug regimens, and I'm not talking about, a really nasty or really four therapy beta or blood pressure regimen or diabetes regimen. I mean, you're talking about like multiple vasopressors, keeping their blood pressure up, multiple antibiotics, and on and on, sedatives, etc. So there's lots of stuff going on with these people. This is a picture of an ICU bed. It's not all that. That's actually pretty typical for what you might see, especially in like a cardiac ICU where you have all those little things kind of floating in the air and infusion pumps, so you have multiple drips going at once. And then you have the comorbid disease states to consider. So these patients, sometimes you might have a healthy person if you work in like a trauma center who gets into a critically ill situation because of an accident or something like that. A lot of times we're looking at people who, especially in like a medical ICU, who might have a lot of comorbid diseases that got them to the point where they're at. So you need to manage those diseases appropriately as well. Fluid and electrolyte changes can be challenging, so you get diluted blood volumes, you get low albumin levels because of malnutrition. You might have to manage the nutrition with enteral nutrition or parenteral nutrition, which we'll talk about here. And then the GI tract may be totally unreliable too. So we'll touch base on a couple of these things. Sometimes, and not all the time, but in an ICU, your patients may be mechanically ventilated, so depending on how progressive their disease is and what it's affecting, what types of organ systems it's affecting. But if they are mechanically ventilated, you're looking at a couple different hemodynamic changes, so decreased venous return, decreased cardiac output, and decreased hepatic and renal blood flow. And then sometimes we do induce therapeutic hypothermia for patients too, which can decrease metabolism in general. So drug metabolism isn't as reliable in patients who are being cooled intentionally. So you have some different things to consider. It's not necessarily something I'm going to test you on per se, but I just think it's something to keep in the back of your head that these patients aren't your standard run-of-the-mill like med-surg patient in the hospital. All right, so talk about hemodynamics a little bit. MAPS are usually what we're talking about. We've talked about MAPS a little bit before, but that's the equation for MAPS. So systolic minus diastolic divided by 3 plus your diastolic blood pressure. Normal is between 100 to 100, and it's just a nice way to trend it as opposed to looking at both the systolic and the diastolic. And of course, you can you can look at those too, but this gives you more of like it's not quite an average, but it almost seems like it sort of is. I shouldn't say that, but it sort of looks like an average picture, right? At least it's one number. It's easier to follow. Indicator of global perfusion for most patients is considered above 60 to 65. That's about the minimum you should target. So most times you're targeting a MAP above 60, and then hopefully a little higher than that, healthy or a patient getting healthier. In the acute areas of illness, they might be hovering around that 60, but we have drugs that can hopefully push them up in the right direction. This correlates directly with volume status too. So cardiac output, stroke volume, preload, and volume all have to do with each other. So they're all going to affect one another. So if your volume down, it can affect everything. So you need to watch patients in and outs as well. Central venous pressure is another thing we can measure, which is a reflective of preload. You can measure pulmonary capillary wedge pressure using special diagnostic tools like Swan's-Ganz catheters and things like that. Cardiac function related to blood volume and left ventricular volume is what you get from a wedge pressure. We talked about wedge pressure with acute heart failure back in the fall. And then cardiac index is cardiac output divided by body surface area. So it's another biomarker or we might use or indicator we might use on how effective somebody's heart is. And then systemic vascular resistance, or what would be more known as just kind of blood pressure, but it's a little bit more fancy term, fancy measuring way to do that. Shock, we've talked about shock a little bit here and there, but just to review the differences in shock, we have cardiogenic, septic, and hypovolemic shock being the primary 3 types of shock. So cardiogenic means your cardiac index is low, your wedge pressure is up, and your vascular resistance is up. Septic, your cardiac index is up, your wedge pressure is low and your vascular resistance is down. So remember septic shock, lots of inflammatory mediators going on, so you're getting a lot of vasodilation peripherally. For cardiogenic, there's something wrong with the actual pumping of the heart itself, right? So somebody's got acute heart failure exacerbation, or maybe they took something cardiotoxic like a beta blocker, which would be beta blocker overdose, but that would still put them in kind of a cardiogenic shock type situation and picture. Hypovolemic, your resistance is usually up because your body's trying to compensate for not having volume, so it's clamping down peripherally. And then you end up with ultimately you end up with a cardiac index decrease picture over time as that wears down. So severe dehydration status or severe blood loss. So ongoing management can be complicated. Of course, you have to know what you're looking at. Some of those are a little more easy than others, depending on what you define easy as. I mean, hypovolemic, you simply replace fluids or blood products, assuming you can stop the bleeding, of course, right? That has to be done first, or at the same time at least. Septic is a little bit more challenging because we have to stop the underlying issue with the infection at the same time, and also try and preserve our end organ function as much as possible. So we've got a couple things in place. Now, if you do that correctly, if you give antibiotics right away, you should theoretically help that process along, but it's not always a guarantee, especially if somebody's pretty far down the pathway into septic shock or severe sepsis. And then cardiogenic shock, we can manage that more so by focusing on the heart specifically, by giving inotropic active medications. But the goal is basically keep your vascular volume restored or normal and prevent that end organ damage. So, and that's going to come with managing the different types of symptoms depending on what type of shock you're looking at. Okay, so restoring volume, crystalloid solutions and colloid solutions. So crystalloid solutions are standard replacement solutions. Colloids, we talked about this during renal a little bit, but that's the breakdown there. So a colloidal product would be like blood or plasma replacement, and crystalloid would just be all your standard maintenance fluids. Colloids they aren't superior to crystalloid. So if you just want volume, pure volume replacement, crystalloid is fine. Now you're going to go colloid if you have a specific reason to do so. Somebody's malnourished, albumin, somebody's low on blood, or you want to replace clotting factors, you might give plasma, something like that. So usually you're looking at a specific reason. Hetastarch and dextran aren't used all that much, but they would be more of a solute strategy to maybe keep a different type. You think about albumin as keeping volume within the blood vessels and pulling it out from preventing like an edema situation, third spacing type situation. Hexa-starch or dextran would do the same. They're basically insoluble like starches that would again just add solute to the blood and pull the fluid in. Again, not used all that much compared to the other ones. If somebody is going to have an adequate pressor response, you have to have fluids on board first, right? It should be common sense by now, but well, say it anyway. You got to get your fluids up and running and continually running, especially if somebody is losing fluids for some reason. And if you give somebody pressors while they're dry, you're going to do a lot of damage in the long run. Okay, so we always do our fluid boluses first, monitor, continue to provide support, and then usually if you give fluids within 6 hours of a shock type scenario that requires fluid replacement, so septic shock, cardiogenic shock may or may not, it really depends on how the person presents. Somebody could present like in a dry state with sort of a hypovolemic plus cardiogenic, so you could get something like that, and you just want to manage whatever you think is most critical at the time. But at the same time, studies have shown that you do get a decent survival improvement if you do give a fluid resuscitated bolus within 6 hours of a presentation of the shock. So that's something that hopefully is happening, right? But you never know, depending on where somebody is, or if somebody was at home, or if they waited a while to come into the hospital, or family didn't call, or whatever it might be. Target again, MAP above 65. Venous pressures 8 to 12, which again is something we can measure specifically. But MAP's usually what we're targeting in the short term before we can get somebody in and get a swan scan center, get something more fancy to measure going on. Urine output is a target we'll eventually get to as 0.5 ml per kilo per hour. So if somebody's fluid overloaded too, we want to keep an eye on that as well. So if we're going the other way with like some sort of a diuretic and we're trying to get fluid off, we want to make sure we're targeting a certain urine output, not necessarily overdoing it too much and not getting them to the point where they're dried out. But 0.5 ml per kilo per hour is a good target, assuming the kidneys are functioning. Titrate fluids to achieve goals. So again, you're just going to titrate based on your blood pressure and based on your MAP. And specifically, if the patient's responding to the fluids, that may be all you need in some cases. So if the map's not met with fluids, then we're going to have to add vasopressors on. So our pressors are a group of drugs that we talked about briefly last fall, but they increase blood pressure or cardiac output, and that gives you increased tissue perfusion. Lots of times, especially in the acutely ill patient, somebody going to your ICU, they're probably not going to respond just to fluids. You're probably going to have pressors on. You might not need the pressors for that long of a period of time, but you probably will need pressors in the short term. Agent selection, largely based on provider preference and patient response. So there are some common agents that we talked about, and we'll talk about again today, but at the same time, it could depend on what the specific provider is comfortable with or what you've had good experience with in certain situations once you see some patients and get some experience under your belt that way. So general targets, beta-1 receptors, increase myocardial contractility and increase heart rate via activity through the sinoatrial node. Beta-2 receptors, you get coronary artery vasodilation and bronchodilation, and alpha-1 and 2 gives you your peripheral vasoconstriction. So just to review what our receptors are doing here. And our primary drugs, kind of in order of alpha activity is how I have them sorted out a little bit here. But phenylephrine, pure alpha agonist, so it's one that's really just going to cause peripheral vasoconstriction. It's never really used by itself, so think of phenylephrine as sort of an adjunct item for some of the other ones. You could maybe, but it's just not very common. Norepinephrine is the workhorse for pressors. It's by far the one you're going to start. It's kind of considered to be the jack of all trades for pressors. It's mostly alpha activity, and then you have some beta activity too, but less so, significantly less so beta-2. Whereas with epinephrine, that's the big difference between the two of them, right? Epinephrine has much more equal affinity for all the receptors. Some people will say that norepinephrine doesn't quite get that beta-1 activity until you get to a higher dose with it. So you start out with maybe some alpha activity. As you push the dose higher, you would get that beta activity. So don't necessarily think of this as purely even. It's really hard to describe pressors in terms of equal affinity because if you change the dose, you can really change the affinity for the receptors that you're going to hit. Because it's going to overcrowd certain receptors and you're going to spill over into the other ones. So in the case of epinephrine, it is pretty much an even shot where you're getting a lot of activity on all the receptors at once, very potent. Norepinephrine, think more alpha, higher doses, maybe pushing more into the beta realm. Whereas with like a dopamine, you have to really get the dose high to get alpha activity, which is a kind of a misconception. I think some people will give dopamine for the beta activity, so it's like inotrope, chronotrope mostly at lower doses. And they'll push it higher and higher, thinking they're going to get more effects on the heart. When in actuality, kind of cap out how much effects you're going to get on the heart, and you end up with more vasoconstriction peripherally because you're getting more alpha activity at higher doses, higher infusion rates. And then you've got dobutamine, which is pretty much a pure beta agonist there. So it's really working on beta-1 mostly with some beta-2. Very minimal alpha activity in many. Technically, they could all work because they're all sort of similar in structure, but if you take a ton of phenylephrine or a ton of dobutamine to get beta or alpha activity, respectively. And we talked about milrinone a little bit. Vasopressin, as you know, isn't part of the ACLS guideline anymore. However, we still use it as drip sometimes. It's a peripheral vasoconstrictor. It uses a bit of a different mechanism, so it uses specific targeted vasoconstriction, not on the alpha system or the beta system. So it's not quite within the sympathetic nervous system per se. So you get some synergy approach when you're adding it to something like norepinephrine or epinephrine if you're doing an epinephrine drip. So commonly what you're going to see is a norepinephrine drip plus maybe adding on something depending on what you want to target. So if you want chronotropic activity or inotropic activity, you're going to add more inotrope like dobutamine or dopamine drip. If you want more peripheral vasoconstriction, you could consider vasopressin. You could consider some more phenylephrine. You could add those both on. So even though you have some bleed over there, so you could think about norepinephrine, well, why would you add phenylephrine to that? They both have alpha activity. Well, you get more with the phenylephrine per se. It's more targeted approach. So there is some synergy that you can get that way, and it does actually work. So it seems a little odd because you're duplicating things, but it does work in real life. Yes?
Is there like a max that you can use for any? Well, I mean, I've never used max.
Yeah, most of them.
As far as time frame, can you? I feel like
yeah.
I'm not sure that you shouldn't use epi for very long.
Yeah, that's generally we'll have patients come into the field a lot with epinephrine going, and our intensivists don't like keeping it running. I don't know if there's actual good data for negative outcomes with long-term infusions. I know with like dobutamine, unless you need it, there is negative data with long-term infusions of that. So I think generally speaking, the longer you have somebody on a pressor, the more dire the outcome, just because, and that's the question is the pressor, is it the nature of the disease they're trying to fight? But at the same time, yeah, I mean, epinephrine's going to be more targeted towards the heart. And I think if you're giving anything that's very strongly inotropic for a long period of time, you end up overtaxing the heart. So, seems to be the body can tolerate a little bit more prolonged alpha activity than it can beta activity, but it depends too. If you have somebody who's in heart failure and the dobutamine drip's keeping them alive, we have people on chronic dobutamine drips for long periods of time too, so it's kind of difficult to say. All right, again, they're all sort of useful in their own right, and there's no good evidence to say we can start one over the other. And most of them will do the job of being a pressor, right? That's basically what they're going to do. They're going to increase blood pressure. They all have subtle nuances to how they do it and what other sort of effects they're going to have. So, like, you could start a dopamine drip on somebody right away, and you're going to get pretty decent effects. You might have to get pretty high to get that alpha activity, whereas with norepinephrine, you might get some alpha activity at a bit lower doses. So, just think about some synergy effects, some kinetic things. People might pick one over the other. So like norepinephrine has a really fast onset. It's very short acting. You can titrate it really easily. Dopamine's a little bit longer acting and might not be as easy to titrate in the short term. So that's another reason, again, why we like norepinephrine. Epinephrine's also similar, very short acting, very fast acting as well. And then pressors can be used in synergy. So vasopressin has good synergy. Phenylephrine, again, good adjunct to any of these to add on a little bit more. Push that vasoconstriction up to the max if you're getting bottoming out pressures. And it's not uncommon in a really severe like sepsis case to have 3 pressors on, to have norepinephrine, phenylephrine, vasopressin all in the same patient. You might see that occasionally, but of course not an ideal situation, but it does happen. Because these are vasopressors and cause pretty profound vasoconstriction, we don't like to give them through peripheral lines. You can. So if you work like ED or urgent care or any type of place where you can't get access to a central line quickly, that's something that you can do. And I always get providers asking me, how long can I do that? There's no right answer to that. As little time as possible. So you want to get your central access quickly, but you also want to keep the patient on a life-saving medication. So there's that risk-benefit there. Usually the benefit outweighs the risk. If it does extravasate, meaning it bleeds, it somehow gets out of the vein, or the IV didn't get through or pierce through the vein itself, and you get some local extravasation, you can get necrosis because of that vasoconstriction locally. It's something we can treat if we catch it right away. There's protocols in hospitals to do that, but it is something that we want to be careful of. With the central line, you just don't really have to worry about that. You don't have to worry about extravasation for one thing. And you can also run it at much higher rates without having to worry about, am I going to constrict this vein off completely, or am I going to cause some phlebitis or something like that? So it's just something to think about. Keep in the back of your head that these should always go through central lines and be central access, but it is okay to do them peripherally for as long as you really need to. We kind of talked about this, how dopamine. So we'll talk about dosing just for a second. So dosing is going to vary a lot for institution. This is one of my biggest pet peeves is working as a pharmacist in the emergency department. Is I get somebody coming in, and it's not like I'm mad at anyone about this. I'm just kind of mad at the process. So you get somebody coming in from LifeLink, and they're the helicopter crew that flies people around, and from rural hospitals to Minneapolis or whatever. And they come in and they're running at like, oh, I'm running this at some such and such mils per minute. And then I'm like, okay, great. I go in and type in ours, and it's like it wants a mic per kilo per minute. It's like, well, we don't have a weight yet, and so sometimes it's difficult to get those doses transferred correctly. So just be patient, and I think it's okay to tell your LifeLink people they can hold on a second while you figure out. You want to make sure the patient gets transferred. I've had more than one occasion where they've just stopped their drips and said, okay, we need to get epinephrine going. And I'm like, well, I can't just magically like manifest an epinephrine. I can get one pretty quickly, or I can make one myself, which I don't like doing, but I could. But the point is that these transitions can sometimes be messy in between health system to health system. So just understand that the dosing might get a little convoluted, and your Epic record system or whatever record system you're using might have a default units that's different than wherever system they came from. So that can be something that you can get over the phone from the EMS or from the provider that transferred them, and you can prepare ahead of time, which is always good to do. Sometimes you don't get that option. It's just life happens. So just a forewarning that the dosing, however it's set up in your system, just might be different health system to health system. And again, higher doses generally for most things, with the exception of norepinephrine, which provides pretty good alpha activity right away, and phenylephrine, which is of course going to provide alpha activity all the time. Higher doses, like with dopamine specifically. There's some people think that with epinephrine, you push higher, you don't really get more beta effects, you just get more alpha effects with it too. You end up with that. So there's an example of dopamine, how you're going to, again, get that beta response kind of in the middle ranges there, and then the higher you go, you get the more alpha response with that. If your cardiac output's low after fluid resuscitation, but your pressure is looking okay, you could consider a pure inotrope right off the bat. This is probably the situation you're going to have cardiology involved with. So maybe you are the cardiology PA and you're making the call here. But more or less, when I get these situations, there's some cardiologist telling me to start dobutamine. I feel like our ED providers aren't usually going to be like, oh, let's go inotrope right away. They're thinking maybe other things. It's not something that they're not versed in, I would say, but it's something that I think that we usually get a cards consult on. If it's somebody who's relatively stable from a hemodynamic perspective, but it looks like they're having some sort of, cardiogenic picture, maybe they have a history of heart failure, they just aren't doing well, they're perfusing well, but their blood pressure looks okay for now, something like that, where you might want to consider, or they respond really well to fluids, but still a little mottled or whatnot. So anyway, there's a number of situations where you could consider changing up your strategy, but usually starting with norepinephrine, not a bad choice for most patients. All right, pressor management questions in general. We'll go on. We can go into sepsis here in a second, but I want to make sure that you guys got that. Most of it anyway. Okay, so first things first, get blood cultures if you're suspecting any type of systemic infection. You don't want to give your antibiotics first and kill whatever you're trying to culture, because then you can't target your antibiotic therapy to the specific organism. Once that's good, you want to give your broad spectrum IV agents. Make sure these get continued. So I say this from the perspective of transitions of care. So this is going to be something we talk about during the next set of slides very briefly. But with any type of transition, you want to make sure you communicate. You wouldn't believe how many people get transferred from our ER to the hospital that don't have antibiotics ordered. And it's not that it's anyone's fault, really. And we've actually developed a fail-safe where we run a report. As pharmacists, we actually have taken this under. So we run a report daily for the whole hospital to see who's got antibiotics in the ER and who doesn't have them ordered on the floor. And most of the time it's fine, but every once in a while you find people. And before we were doing this, it was getting caught, or wasn't getting caught frequently enough. And it can be a big problem. So again, just make sure that if you're starting something, somebody's continuing it, or somebody has a rationale for not continuing it, would be okay too. If somebody's like, no, why did you give them that? They don't need it. That's possible. It happens all the time. Don't feel bad. Especially if you work ER and tend to go big in the ER, then when you get to the floor, the hospitalist or intensivist might say, no, this isn't that, this is something else. Well, whatever. That's what I thought it was. All right. Control the infection source. So whatever it might be, IND, debridement, device removal, whatever you need to do, that's sort of a no-brainer for sure if you can nail that down to a specific thing. De-escalation. So based on your culture data, watch those cultures on a daily basis. Look at the clinical picture of the patient. Are they improving? Sometimes you don't really have good culture data, but you know that they're doing pretty well on the current regimens. The question becomes, what do? Do you keep them on this broad spectrum regimen, or do you try and wean down something? And that can be really tricky, and I think it depends on how critically ill the patient is otherwise. You could certainly try to take something off, so maybe you try cutting out the vanco. If you started them like Vaco and Zosyn, and assuming they're doing okay, they're out of the ICU, they're out of the woods for the most part, that might be ideal. Or maybe you switch them to oral therapy and see how they do with that. Or maybe you think it's probably a pneumonia source, you never really got a good culture. Switch them from something really broad spectrum to like an oral fluoroquinolone. Something like that would be appropriate. Generally speaking, with sepsis, assuming the person's responding to the initial treatment strategy, 7 to 10 days is appropriate for most people. Bloodstream infections usually do respond well to antibiotics, so it depends on where the source is, right? But if it is a bacteremia, you're getting the antibiotics directly into the blood by intravenous infusion, right? So you're getting it directly to the site, and hopefully that'll get it to the underlying area while you can maybe control some of the infectious sources if there's another source. All right, discontinuing antimicrobials if no infectious source or evidence is found. So if the patient's doing better, you just have zero data whatsoever. If their white cells are looking good, if they don't have an elevated lactate, if their hemodynamics are fine, not febrile, and maybe they did look kind of maybe a little bit septic at the beginning, that would be a sign where you can probably remove things, start getting rid of some stuff. I always recommend IV consults for these types of patients. I don't think you can go wrong, especially if you have a sepsis consult, to get IV involved. You might be the IV person. I know we have a couple IV PAs at our hospital, but if you aren't, just make sure that that's the team you're including. I think they provide probably a pretty invaluable resource. So that's sort of sepsis in a nutshell. There's, of course, some other things we can talk about here that are sort of a little bit off the beaten path. Glucocorticoid use. We talked about antibiotics and ED, so I'm not too concerned. We rehashed that a lot today. It's the broad spectrum approach that we mentioned last week. And then you would narrow it as appropriate. But the other medication people sometimes give in sepsis are glucocorticoids. So if this is controversial for one thing, so this is not something that's absolute, not something you're always going to do. But for patients who have severe septic shock with systolic blood pressure below 90 that aren't responding very well to fluids and pressors, you'd end up looking at maybe considering a glucocorticoid. So the problem is that if you measure like a plasma cortisol or corticotropin, some other types of stimulation testing, you might not necessarily get the most reliable test because this person's critically ill, their body's taxed, they're releasing a lot of epinephrine, norepinephrine into their system already. So the question is, like, can we really measure how responsive these people's adrenal glands are going to be? And is it necessary to even do this? So the evidence is mixed. There's not really a good yes or no that it actually helps. And I think for most cases, it's probably not super beneficial. However, in those patients that nothing's responding, their blood pressure is not responding to anything, they're on 3 pressors, max doses, doing lots of fluids, for some reason they just aren't responding, they will give IV hydrocortisone occasionally. And so again, it's kind of a last-ditch effort, but it's something that is somewhat studied and somewhat proven, but there's controversial evidence for whether or not it's useful. You can do, I think I talked about this back in the fall, but you can do a cosentropin stimulation test, which again I can say could be unreliable in a severely ill patient, but you could test to see if their kidneys are going to respond, or their adrenal glands are going to respond by giving an ACTH analog that's going to stimulate release of epinephrine. So then you can measure, or cortisol, excuse me, not epinephrine. So you can measure plasma cortisol levels after you stimulate that with a specific test agent, which is just a medication you give IV bolus. But again, in a critically ill patient, is that valuable, or can you actually get a response from them? That's a great question, and generally probably not. So again, glucocorticoids maybe, but definitely not the primary treatment option for a septic patient. Pain management. Critically ill patients likely are experiencing a lot of pain. They probably aren't going to be able to verbalize it or show you per se. I'm going to show you some ways nursing can figure this out and some of the scoring tools they use. But some patients might be fine. They might be with it enough to tell you. Other patients might be totally mechanically ventilated and paralyzed, so you have no idea really what type of pain they're in. So sometimes we think about sedatives and analgesics going hand in hand, and you might want to consider a drug that does both. So this is where fentanyl can come into play. So fentanyl drips are really popular in the ICU for these reasons. It treats the analgesia. It also provides as a short-acting sedative that is easily titratable. We like, for people who aren't on like a continuous infusion, IV opioids are what we're going to use. So these patients are critically ill. They're likely undergoing a lot of pain. And if they can verbalize their pain, they're probably going to tell you that. So morphine, hydromorphone, and fentanyl are our friends here. You could, of course, use the standard pain meds like IV Tylenol. Yes, we do use IV Tylenol sometimes. Ketorolac would be our IV NSAID we could use for these patients. And when I say IV, most of these patients aren't tolerating oral medications, at least not right away. Especially if they're mechanically ventilated, they probably have a G-tube. So instead of crushing up everything or making your nurse crush everything, it's a lot easier just to give an IV bolus of something. Not that I'm advocating, flagrant use of IV acetaminophen, because it's really expensive and not all that beneficial, I don't think, but it is an option. So again, I'm just pointing out that there are ways you can promote a synergy approach here. You could certainly give oral too. We can give oral liquid Tylenol, that goes down a G-tube pretty easily. You can give liquid ibuprofen, again, that can go down a G-tube pretty easily too. So not the end, or an NG tube, I should say. Not the end of the world. Dose achieve target pain goals. So we want to keep our sedation goals in mind. So you want to target pain without over sedating the patient. So it depends on what sedation goal you're targeting. We'll approach that here in a second. And continuous infusion, intermittent, scheduled PRN dosing is all things you're going to think about. So again, it's about what you're trying to do with the patient specifically. So you're trying to keep them sedated with the analgesic as well. well, that might be a fentanyl continuous infusion. Or you might do a PCA where the patient's with it enough to manually use their PCA occasionally, so they're getting a continuous rate off the PCA and they're bolusing themselves. Maybe the patient's not in a lot of pain. Maybe they're in the ICU because they just had a major surgery, but they're doing okay, and they can handle PRN dosing. Or you could just do intermittent scheduled dosing. So there's a number of ways you can do that. You can trial numerous strategies, but a lot of times these patients are going to end up maybe on an infusion and then working down off the infusion to maybe some sort of a scheduled pain regimen, and then ultimately to PRN, ideally. So that's in a perfect world, but of course it doesn't always work out that way, but that's generally what you would see as somebody moves from most severe to lower severity. All right, so how would somebody tell somebody who's ventilated what type of pain they're in? Well, these are some of the proven scales, or not proven, but studied scales that show you what you can look at as far as somebody's movement. So now when somebody's completely paralyzed, it's very difficult to see anything, right? So somebody who's paralyzed is probably going to be on a fentanyl drip anyway. So the question is, do you really need to go beyond that? You're probably going to titrate it to make sure that they're staying sedated via looking at their hemodynamics and their respiratory rates and things like that, how much they're fighting the ventilation, mechanical ventilation. But in these patients' cases, you can look at some of the similar things, but somebody who's mechanically ventilated and sedated won't be paralyzed unless they're a really difficult case or unless they're being therapeutically cooled for some reason. So in these patients' cases, they're going to have facial movements, so you can monitor that. Upper limb movements and compliance with mechanical ventilation is big. So they talk about the term bucking the vent. How hard is somebody working against the mechanical ventilation? That's a big sign that A, they aren't sedated enough, and B, that they're having some kind of a pain syndrome going on. So those are some ways that nursing can assess at the bedside with these patients who aren't really able to verbalize anything. Looking at some of the more subtle things like facial expressions, some of the big things like upper limb movements and vent compliance would be pretty obvious if you saw it happening. So with sedation, your opioids might be enough. So again, we're targeting pain management first generally. So maybe that fentanyl drip's enough. Maybe you don't need really anything else. Maybe they're doing great on the mechanical ventilator and all they have is a fentanyl drip going. A lot of patients are going to use something else too. You can combine opioids with pretty much anything else. So you could combine opioids with propofol or dexmedetomidine. Dexmedetomidine and propofol are two of our favorite sedatives in the ICU. We've talked about those already a little bit. Benzodiazepines, you can use very small doses. We don't like benzos as much as we used to because they're heavily associated with delirium. And they prolong mechanical ventilation, which leads to increased ICU length of stay, which is a big extra expense in the general healthcare system. So benzos are fine for some cases, like for irretractable seizures or people with neurologic conditions that are causing seizures. That's a great drug to try, keep somebody sedated on, because it will help with the seizure suppression as well. But ultimately, you do have to weigh the risks with the benefits here, and the risks being the delirium and increased length of stay. So try and avoid our benzos if we can. We prefer opioids, have some delirium risk too, but not as much risk with length of stay. And propofol and dexmedetomidine generally are pretty well tolerated and don't necessarily have those same complications. So let's talk about propofol again, because it's a fun drug to talk about. Propofol, we talked about it very briefly during anesthetics. We talked about it very briefly during ED. This would be not necessarily a bolus of any type, but this would be your continuous infusion. So let's say you're in the ED with your patient. You get your RSI completed, so you've paralyzed and sedated your patient. You put in the breathing tube. They're on the ventilator. Now what do? Well, you usually start a propofol drip on most patients. Unless they're really, what's the big issue with propofol? When do we not want to give propofol? Anybody remember? Yeah. So egg and soy. Yeah. Okay. So there's that. What about more commonly? So that's not super common, but like what's something that you'd see as far as like hemodynamics go? I think it's up there. Hypotension. Yeah. So somebody's severely hypotensive, you'd probably skip the propofol and pick something else. Dexmedetomidine can cause some hypotension as well. We'll talk about that in a second. But fentanyl Versed, it's a pretty good combination. It's not super effective to hemodynamics. So in that case, maybe the Versed would be a little bit better because you're going to get, or the midazolam, should be not use brain as much. But anyway, midazolam would be a little bit more hemodynamically neutral in that case. Propofol has no analgesic activity, so we've got to make sure we're addressing pain as well, whether that's IV boluses intermittently or some sort of infusion. It does have caloric content, 1 kcal per milliliter. So when you're doing nutrition replacement on these patients, which we'll talk about in a little bit, we do take this into consideration. So you wouldn't think it'd be that much. It doesn't come out to all that much, but it is mostly fat. So we can decrease the lipid infusions we're giving these patients a little bit. And then there is something called propofol infusion syndrome, which is super rare. I've never seen it, and I've never actually heard of a real case of this, but there are documented reports in the literature. High doses for extended period of time, somehow this interferes with mitochondrial metabolism, which can lead to an acidosis, cardiac failure, arrest situation, renal failure, lots of really nasty stuff. If it does happen, the documented cases have shown it's pretty much always fatal. There's not really much you can do about it. So when you do propofol, you work your way up kind of slowly. I've had people really aggressively want me to start a propofol drip high, and if a provider wants to do that, I can only tell them not to nicely once, and then if they want to do that again, that's fine. I don't think it's a rare thing, and I don't think it's a huge risk, but I would start somebody at a conservative rate of propofol. Propofol is pretty easy to titrate in the early phases. It's got some odd kinetics where the longer you have somebody on propofol, the more it accumulates in the fatty tissues, and the longer its half-life becomes. So that's why in the short term, when you're giving it as like a short-term sedative, it's very fast-acting, very fast offset. When you have somebody on an infusion for multiple days, it can actually take a little while to get them off the propofol and wean them down because there's so much accumulation that happens. It's got this odd kind of 3-phase kinetic profile. So the higher doses you give for the more extended period of time, the more accumulation you get, which is where this theoretical risk comes from. And again, you just need to be careful with how you're titrating it up. And I think, especially in the early phases of propofol, it's always easy to add more. If you give somebody a ton right away, you're just going to oversedate them. It's going to be hard to gauge exactly how much you oversedated them. So I always recommend starting conservatively and working your way up slowly with a continuous infusion. So again, you get fast results, but sometimes respiratory therapy gets mad because the person's aggressively bucking the vent and they want them sedated fast, and I get it, but I'd also want to watch out for the safety of my patient. So yeah. And you're wondering, why are you talking about this? Who's putting you in charge of this? And it's sometimes a little scary, right? No, what happens is I'll get in a situation with my nurses, and the nurses are the ones who are the ones titrating it because they're looking at the bedside. They have a orderable dosing range, right? So it says give anywhere from 1 to 60 micrograms per kilo per minute of propofol, and they will titrate that based on how they're doing. And so they'll say, Chad, what should I start this at? I'm like, I don't know. Let's try 20. That's my given propofol starting dose. And then the respiratory therapist pipes in and says, no, start him at 60. And then I say, no, we're starting him at 20. Sorry. Yeah. So that's how that goes usually. So if you'd like to be involved in those really fun conversations, feel free. Okay. Pressors is something I honestly don't have a ton of experience with as a non-ICU pharmacist. I know our ICUs love this. They use it all the time. But I don't start this in the ED, and not to say we shouldn't. Maybe we should be using this more. It's just not happening. I think I have seen them doing this more for OR cases that are going to the ICU as sort of that ongoing sedative agent as opposed to propofol. So Pressors is a little bit different than propofol with its kinetics. It's got pretty fast onset, but much slower than propofol. Duration is longer, so when you're stopping it, it's going to take a little longer for it to wean off, again, depending on how long the person's been on propofol, but usually Pressors can take a while. Hypotension with the loading dose, usually we don't load people with Pressors. You're starting a drip and continuing gradually, so people don't usually get a big hypotensive response to this. There's sort of a debate on whether you should watch out for people with existing hypotension. I think a lot of the times when they're using this, they're giving it at a rate that's not affecting blood pressure all that much. It's kind of like a clonidine analog, so you might get some centrally acting alpha effects, but that might affect the person substantially. It might not. Depends on the patient. So it's something to watch out for, but it's not like, and I should give the caveat too, that propofol doesn't have an absolute contraindication to hypotension. If somebody's hypotensive, like in the 90s, I've even seen us give propofol systolic in the 90s, and people have done pretty good. It just depends. If somebody's really low, like struggling, I'd probably watch out. But if you're on several pressors and fluids and you're barely hanging on to like a MAP of 60, it's probably not a good person to do propofol on. But if you're kind of borderline, it might be okay. And I think the same thing would go for dexmedetomidine. It's a good one to try. So it's a very effective drug. and has really good outcomes as far as ICU length of stay and delirium rates, very low compared to a drug like midazolam. With propofol, it's debatable if one is better than the other. I think there's situational use for them. I think when it comes to dexmedetomidine, people are in almost like a wakeful sedation. You can wake people up while they're on dexmedetomidine with, a sternal rub or something. Propofol, it might be more difficult to do that. So for neurologic assessment, dexmedetomidine might have an advantage there. But they're both good drugs. There is a study that said patients seem to require less analgesic medication while on dexmedetomidine versus propofol. The question is were they able to assess that better potentially, and were the nurses who were involved with the study maybe going a little bit overboard with propofol because they couldn't necessarily tell as much? It's something that we don't know for sure. And they haven't really done great head-to-head studies on ICU length of stay or delirium. What we do know is that benzos are much worse than both propofol and dexmedetomidine. So it's not like we can really compare them head-to-head per se right now. So dexmedetomidine is a bit more expensive than our other ones too. So, but so is an extra day in the ICU, right? Yeah.
Is there any withdrawal with any of the sedative?
Not if you do it correctly. So they'll do vent weaning trials on patients where they pull off the sedation and see how well it goes and see if they're ready to maybe try pulling out the vent. But I think if you titrate it down appropriately, you're giving usually with propofol. I think you get in a situation where you've had a lot for a long period of time. But with something like dexmedetomidine, I think you would have a good enough offset period where you could titrate them off easily. Because if you think about it, you're getting such a small amount that's continuous. It's not really like they're building it up and there's also should be metabolizing it pretty well. But yeah, it's always a risk. You might see it occasionally, but you can. That's a nice thing about these titratable, easy on, easy off medications. You can always turn it back on a little bit if you start to see some sort of either agitation or increased spike in hemodynamics like that.
And then with benzos, if you did have to use a benzo.
Yeah, that you'd want to be very careful with. Same with the opioids for seizures with benzos, and then of course it was the comfort factor with opioids. Yeah, that would be a different scenario. Usually with those, we've had people on really high Versed drips from the ICU transfer, and they might end up being on like a really high dose oral Valium regimen for a while. Remember, diazepam's really long acting, so you could give like a once daily oral diazepam to titrate them down that way, so they aren't on something IV continuously. That's a strategy we do too. Sometimes you end up with like an alcoholic patient who's on just a ton of benzodiazepine, either for withdrawal or for sedation or both. Yeah. I put this on here. This is the RASS scale, or Richmond Agitation and Sedation Scale. RASS is a really commonly used goal for sedation. So when you see somebody or if you're a provider ordering a sedative, you might target, let's say, goal of -3 for RASS. So you want moderate sedation. You want movement or eye opening to voice, but no eye contact. Usually what we see for ICU patients is like a 3 and -3 to a -4 as a target. 5, I've never seen anyone want unarousable patients completely. Usually if you can get a little bit above that, that's ideal. But light sedation is usually not enough for these patients. So somewhere in there. So that's where the dexmedetomidine can be really nice, because it targets a 3 a bit more easily than your propofol and your Versed fentanyl drips do. You can see 4 would be something we don't want to go to either with the combative and very agitated. So that'd be a way we could say, well, somebody's delirious, they're a 4 on the RASS system, we need to target something else. But RASS is generally used as a negative, looking at the negative side of the scale and saying, okay, we want to target a specific level of RASS. Not necessarily saying, oh, the patient's combative, they're at a 4, but you could use it for that too. So. This is just an example of a flow sheet I pulled from some hospital, I can't remember, but it's sort of a standard way that a nurse might assess RASS. So if they were looking at targeting something in the middle of like a -3 to +4, which would be really high end. So anyway, there's a number of different ways that they would progress through, or depending on how low the sedation is going, if stopping it. So the point of this is I wouldn't test you on anything like this, but that nurses will have protocols with these types of systems in place where if they have a specific score, they might move through a different series of protocol, and then they can test different things that way. This is something that is a delirium assessment tool. So I think delirium is something that's a huge area of continued improvement for our ICU patients, specifically due to the group of medications they're receiving, right? So they're getting all these benzos, fentanyl, whatever, opioids, you have a number of cases of delirium and a huge risk for delirium. So this was a poll that looked at specifically nurses and what they knew as far as using different tools. And the number of nurses that rarely ever use psychiatric consultation is kind of astounding. That would be a huge tool to use. But just using different scores, so like CAM-ICU is a scoring system. CWA, that's an alcohol withdrawal type protocol. I'm not expecting you guys to really know these, but as far as looking at events, and then some of them never even hearing of some of these tools. So I think if we were to look at this as old, it's from 2008, but if we were looking at some of this stuff in maybe more modern literature, I think hopefully we'd see a swing this way. But the point is that delirium assessment, not really a perfect way to do it. And if we can target it more on the medication front before we get to the point of delirium, that's of course ideal. So that's why I want to spend enough time talking about these agents so that we understand that. But yeah, you can always get psych involved. I think that's a great tool that I think people kind of forget about sometimes with these patients. All right, so continuing on delirium. So what if somebody is delirious? How do we manage it? Haldol, haloperidol is a great choice. It's got some issues that we've already talked about. Doesn't necessarily reduce the duration of delirium, but it will help with those acute agitation symptoms, and it will do that very effectively. QTC prolongation, extrapyramidal symptoms being your two biggest side effects to watch out for. A lot of times they'll see if they can get a dose titrated up to a good effect, and then give it every 6 hours or so until the patient's delirium improves, or until you can remove enough agents. Maybe you can get them off their midazolam drip and switch them to propofol or something like that. Second generation antipsychotics work well too, and are much more preferred probably nowadays. Nothing seems to really beat haloperidol in the short term. If you really have a super anxious patient, a shot of IM haloperidol does wonders for that. However, you do have several side effects that you really don't get with the IM second generations. And olanzapine is quite effective for that too. You give a pretty big dose of olanzapine IM or even IV now, we can do that. That's something that is, again, quite acceptable and probably preferred in a lot of cases, just because you have less side effects. You don't have that QTC, you don't have the EPS with olanzapine. In fact, it's pretty well tolerated in the short term. Just might get a little bit of sedation with it, which you probably already want on your patients, right? Maybe the downside of giving these medications is thinking about like continual outcomes with them. So what's ultimately your end goal? That's where there's a lot of controversy, I think, with treating delirium. Is you have to have some sort of a plan in place. You can't just give somebody antipsychotics for the rest of their hospital stay. It's probably not going to help. So you really need to use these as controlling acutely and work on a long-term plan at the same time, long-term strategy. Either removing medications, decreasing drips, trying some other sedation strategy, whatever it might be, you need some kind of a plan. Because this isn't really sort of a Band-Aid, right? And then our big three drugs we talked about in the geriatric section apply here too: benzos, opioids, anticholinergics. Those are your three major targets. The three what we'd think of low-hanging fruit for what might cause a delirium episode. All right, therapeutic paralysis, or therapeutic hypothermia, which kind of go hand in hand a little bit. So most of the time, if you're paralyzing somebody for a long period of time, so we talked about paralytics with RSI, but usually that's short term, right? So we aren't continually paralyzing people. Occasionally we do that, and therapeutic hypothermia is probably the most common instance of that, and that's usually just for a day. So we aren't really paralyzing people for long periods of time. Sometimes patients with persistent hypoxia, despite adequate ventilation placement, despite adequate sedation and analgesia, for whatever reason, they might respond better if you just paralyze them altogether, and the vent can work uninhibited that way. Sometimes we'll see that. That, again, should be short period. Control severe intracranial hypertension with neurologic injury. Some people with like a severe intracranial bleed or something like that might respond well to a brief period of prolonged paralysis. But again, we aren't talking about probably more than a day really in any of these cases. We're still going to try analgesia and sedation first, like we would with all of our ICU patients. And you do need to have that continuously infusing sedatives. Remember, we talked about sedative first, paralytic second. That, of course, applies here too. We never would use a paralytic drip by itself. You increase a lot of risks of adverse effects, so it does mask seizure activity, which can be a problem, especially if the patient's got some sort of neurologic complication. neuromyopathies, insufficient analgesia or sedation, increased risk of VTE, possibly leading to skin breakdown, corneal abrasions. It requires a lot more work on the nurse's side to take care of a chronically paralyzed patient. But I mean, it's something you can do. It's just know that there's a lot of risks involved. So hypothermia, what we're going to do is target 32 to 36 degrees Celsius. I kind of think about like getting frozen in carbonate, although not quite as cool, a lot more. Yeah, anyway. So 24 hours, and then you usually gradually rewarm the patient at a rate of about 0.25 degrees Celsius per hour. So we have these really cool cooling catheters that go into the femoral artery like this. And they do, not femoral artery, what would that be? Veins. And, yeah, I don't know, anyway. My anatomy's bad. Forget I said that. I'm thinking of femoral artery sticks, which isn't what that would be. So anyway, you get a cooling catheter in there, and it's just a cold water pipe, right? It doesn't have any outlet to it. It's just got an end piece that you're putting in there. And by going into the gray area, it can control temperature pretty well. And these machines are pretty smart too, where they can monitor temperature and adjust the temperature of the water to get that temperature just right. So yes, you can pack ice in people's groins and armpits and stuff to make sure that they get down in the beginning time while you're waiting for this thing to get in. Other strategies we can do, there's these cooling pads that are like these big kind of gel pads that go around people's body parts, and those can be done too, but the cooling catheter is by far the way to go. It's really easy compared to a lot of these other things where you have to stick them all over people's bodies or pack ice and get water everywhere. Cooling catheters are sweet. They saved a lot of time and space and everything in our hospital. So anyway, you're cooling somebody. The idea is that you reduce the risk of overall neurologic injury in a post-cardiac arrest situation. There's pretty good evidence to support that it does work. Now, you have to, I think, keep your optimism a little bit on the downside, because it's not like people are coming back, from a terrible arrest and are great. I think you have to take into consideration what type of arrest it was, how long were they down for in the beginning. All those things would come into play just like they would, in a normal situation. But the evidence does support that this is generally the way to go for these types of patients. So until we know otherwise, which may be the case, maybe in 10 years we'll find out this doesn't really help anyone in the long term. But for now, this is the standard of care when it comes to post-arrest care. Now, just the caveat being, if somebody's talking to you, if you shock somebody out of a rhythm and they're awake and talking to you, you don't want to sedate them and cool them. That doesn't help, right? Just to make sure that's clear. All right. All right, a couple other, some other quick random things. Hyper and hypoglycemia. So the question is, how do you control blood sugar in the ICU patients? This can be really tricky and challenging to do, especially if you have somebody who's getting parenteral nutrition. The moral of the story is there's two studies that came out. One was in 2001, and it targeted a really tight blood sugar between 80 and 110. And it said that people had better mortality benefits in critical care situations with a tighter glycemic control. No one could duplicate these results, and in fact, there was this big study, a larger study in 2009 called Nice Sugar, which is sort of a landmark study that showed that it actually increased the risk of hypoglycemia substantially, which shouldn't be a surprise to anyone, right? Tighter control is always going to increase your risk. And then target blood glucose less than 180 in that study showed that the outcomes were just as good as a tighter control group as mimicked by the 2001 study. So we don't target aggressive glycemic control in ICU patients anymore. We target that below 180, and anything within that is fine, assuming they're not hypoglycemic, of course. We've got these really nice insulin infusion protocols that have developed within the last couple of years that we've adopted, and it's all nursing driven. So this is a provider, you would order it, and then the nurses will go through a number of questions, and then this thing we call Endo tool. It's called Endo because it must be endocrine, I think. Everybody thinks of endoscopy and like, why is this called Endo tool? It's an insulin infusion protocol, whatever. It's called Endo tool, and our hypoglycemic rates have like fallen off a cliff. We have virtually none anymore now that we're doing this because this thing is very vigilant. And at first our nurses hated it, but now I think everybody's kind of on board with it. So it's something that will basically tell you exactly what to do. So you put in the blood sugar, you put in some other parameters, and it says, okay, start the infusion at this. And then check your blood glucose in this amount of time. You check your blood glucose, put that in. It tells you again what to do. So it's very, very nice and pretty simple, but it is something that I think is a bit challenging if you aren't familiar with it. From a provider aspect, Even from a pharmacist aspect, because I don't really do it, our nurses do. I get questions on it, and like, I don't know, I'm not even technically trained to do endotool, but it's something that from a provider aspect, if you do work with these patients and you use these protocols, you might want to take the time to sit down with the nurse and see how they actually plug it in. Because they might call you and be like, I'm running the endotool and I don't know what this is. And you're like, I don't know what that is either. But yeah. Anyway.
Is that why like some patients are checked every 2 hours versus 4?
Yeah, usually it depends. It could be like if you have like a DKA patient, yeah, the protocol might say to do more aggressive versus a patient who's just hyperglycemic, for some other reason, or you're just trying to get a tighter control on. Yeah. Mm-hmm. Stress ulcer, mechanically ventilated patients or people with any type of coagulopathy risk are at risk for stress ulcer. And so we like to treat them accordingly. So there's some other risk factors here, but the majority of patients that are going to apply to this are going to be mechanically ventilated or on anticoagulation for some reason. IV H2 blockers are a drug of choice for critical care patients. They're effective, they're cheap, and they have really good bioavailability when given PO. So if you can get them down a G tube, you can do that, or an NG tube, you can do that. IV PPIs are fine. There's no problem with them. They're just way more expensive. So to save some dollars, we like our IV H2 blockers in this case. If the patient doesn't have any risk factors at play anymore, please stop these drugs. This is probably one of the biggest things we see people just get continued on. And I've probably said this before, but it bugs a lot of my friends, and so I have to represent them here. I don't personally get on a high horse about it, but it's something that a lot of my friends who work like in med surg areas constantly see people transfer out of the ICUs and they're still on PPIs for no reason. Just there's no point in continuing it. So it's just a matter of prophylaxis. Stop it when you don't need it anymore. Once the risk factor is gone. Don't use Tums, any type of antacids. Those don't work for stress ulcer prophylaxis. So stick to your H2 blockers or your PPIs if you need them. DVT-PE, you have an immobilized patient, so of course that's a big risk, big concern. So question is some of the history, elderly, obese, history of VTE, sepsis, heart failure patients at higher risk. Mechanical prophylaxis is something that's done quite a bit. These things called pneumo boots, or they're pneumatic compression boots. They look kind of like this picture I have here, like a big moon boot, and it is a compression. It has sort of like think of like maybe a massaging chair, sort of like a wave thing that's a lot firmer and more controlled, I should say. But it's pushing blood around in the lower extremities to prevent those DVTs from occurring. Pharmacologic options are certainly something we can do too. So we give prophylactic heparin a lot. Sub-Q heparin prophylaxis is cheap. It's very effective. You could do once a daily enoxaparin as well. That's something that a lot of institutions use. It's more expensive, but it's equally as effective. So those are kind of the big ones for PE and DVT. But the pneumatic compression boots are a nice non-pharmacologic option for the people who don't tolerate these things. So again, subcutaneous heparin, usually it's just a fixed dose every 12 or every 8 hours. So it's pretty straightforward that way. And then you've got Lovenox as well, or enoxaparin. You can do IV heparin at a really low infusion rate, but generally, why would you if you can give sub-Q? The only time we might do that is like on a really obese patient who has a lot of subcutaneous fat. Enoxaparin data for really obese patients is a little iffy at best. So it just maybe makes more sense to do the IV infusion at that point. But for most patients, the sub-Q products are just fine. And of course, if a patient's already anticoagulated, like if they're on warfarin therapeutically and it's continued, if they're on a new oral anticoagulant, that would be something that you would continue. You aren't going to need to prophylax them with anything else. Nosocomial infections, foam in and foam out. We talked about CAP during ED a little bit, but this would be sort of a more advanced form of this. So ventilator-associated pneumonia, something that can happen with ventilated patients. So you get patients who have think about it as just access to the lungs, right? So you have a tube going into the lungs and down the trachea, and then it gives a pathway for bacteria to get in. So how do we stop this? Minimize ventilation. Daily vent weaning assessment is appropriate. So basically making sure that the patient isn't on a vent any longer than they need to be. So ask every day, does this patient still need the mechanical ventilation? Maybe they do. Elevating the bed has actually been shown to be quite helpful versus having them completely horizontal. So it just limits the amount of aspiration of stomach contents that can probably get into the lungs that way. It also helps with any type of transmission from the exterior of the body. Oral antiseptic here, chlorhexidine rinse is something we use a lot, which prevents any type of oral microbe from getting in. And GI motility, using the gut as often as possible to ensure motility has actually been shown to be effective at that too. Limit antibiotics, PPIs potentially can cause C. diff as well, so limit those. And of course, don't expose your patients, which is where the foam in, foam out method comes into play. If you do get BAP, it's a broad spectrum approach. You treat it with, vancomycin and then narrow down from there. So it's something you would treat very aggressively because you have no idea what nasty bug from your hospital crawled into that person's lungs while they're in your hospital. So you want to cover pretty much everything. Okay, so nutrition support. You have, usually this is managed by a combination of pharmacy and dietary, depending on what hospital you're at. We have a collaborative effort. Basically, our pharmacists do the work, and then we call dietitians and say, hey, is this good? And they say, yeah, that looks good, or no, that's too many calories. Some hospitals, I've heard the pharmacists will manage like the micronutrients or the trace elements type things, like the electrolytes, and the nutrition would manage like the caloric intake, so the protein and carbohydrates and fat, which is probably the ideal way to do it, I think. But anyway, at our hospital, we do pharmacists pretty much control the whole thing, and then we confer with dietitian. So enteral nutrition is always preferred over any type of parenteral nutrition. We want to use that GI tract if it's working. It's less money, improved healing, reduces risk of complications. The problem is tube feedings might interfere with medication absorption, but that's a minimal risk compared to the benefits of GI, of using your active GI tract. Parenteral nutrition, or total parenteral nutrition, why it's called total, I don't know. Most people call it just parenteral nutrition. However, TPN is the abbreviation we use. You want to consider if they're intolerant for enteral nutrition for about 7 days, then you'd consider starting parenteral. And a late start versus early start. So 7 days is what sort of the literature fell on. There were some studies that looked at starting people right away on a parenteral regimen versus waiting a while. And they found that you can wait about a week with pretty decent outcomes. Now, it depends on the patient, what's going on. If they're severely malnourished, maybe you want to start it earlier. Formula is really complicated. I'm not going to ask you any test questions about TPN formulas because I have a lot of trouble with them. You have to have a lot of practice with these to be able to do all the calculations, but I'll walk you through it very briefly so you're at least exposed to it. A TPN is basically a big IV bag that looks kind of yellow like that. It's got dextrose, amino acids, electrolytes, vitamins, trace elements, and then you usually hang lipids separately. So you can see the lipids hanging up here, this bag of white stuff. Gross. Yeah, that's kind of gross. Okay, so just to run through this really quickly. Again, this is I would like you to know for a test question like what TPN is and what might be in it and like when we might use it. But as far as calculating anything, don't worry about that at all. So you're going to want to figure out your total daily caloric needs. There's a couple different equations we can use to figure those out. And there's stress factors. So like if you have cancer, it might multiply it by a stress factor that increases the caloric needs a little bit. We figure out our protein goals. Usually you're looking at 1 to 2 grams per kilogram per day in protein. That's part of your total calories, so you factor that in. So you calculate how much protein an average person would need, minus it from your total calories. That gives you a remainder of calories. You look at lipids, which is usually kind of a set amount. Now, if you're on propofol, that might add a little bit to that. But normally we're doing lipids, kind of a set amount of calories, which is a percentage normally. And then we're balancing it out. So lipids about 25 to 30% of total calories. Dextrose is the remainder. So you're getting your protein, getting your lipid percentage, and then you're making up the rest of it with dextrose as your carbohydrates. So that's essentially what TPN is. You can, of course, tweak that. You can make it more protein focused. Sometimes if there's like really nasty wounds that are healing, we might go with a slightly more protein heavy regimen, but there's not like good evidence per se to support that. It's just theoretical. And again, your dietary people might say, no, I want their lipids to be down or I want their dextrose to be down a little bit, but it just depends on how the numbers fall, I think. And also compatibility. We can only make these things certain ways. If you overdo it on one end, if you want, let's go with like the Atkins TPN, which is, I'm joking about this, by the way. But let's say you want to go with an all-protein one, it's just not going to work. You can't do that. It's not going to be compatible with the other solutions you need to add into it. Okay, I should have said paleo because that's more trendy now than all right. So everything else, electrolytes, you're basically following daily labs and trending them appropriately. So you're giving people electrolyte replacement and watching how they respond to that. It's usually pretty subtle. You aren't like hammering people, and it's not uncommon to see somebody get a lot of extra like potassium replacement while they're on a TPN. You just can't add that much to a single bag, so you might have to replace additionally. Trace elements are pretty standard. There's like chromium, selenium, zinc, that type of stuff. Multivitamins, again, there's a standard IV multivitamin formulation that we give to TPNs as well. There's some other things that you can put in. You can up the zinc a lot. You can add a ton of zinc to it. That's thought to improve wound healing in some patients with maybe like an active like diabetic foot ulcer or something like that. But there's some odd things you can monitor too for. We look at FOS, triglycerides, CBC, which is an odd, but LFTs. Sometimes we look at ABGs too if they're getting arterial blood gases, but usually we're getting all these labs fairly frequently. So there's a lot of labs, heavily protocol-driven process in most institutions. So there's a lot of behind-the-scenes things that drive all these factors that we're changing and making sure that our formula is staying on our protocol, basically. One thing you might see occasionally is something called refeeding syndrome. So if somebody's been malnourished for a while and you give them a lot of calories, they can end up with sort of going overboard where their cells like almost are, I don't know, think about like being starving and then going to a giant buffet. And it does increase a lot of different processes. One of the things you can see is some really sudden large spikes and changes in electrolytes. So one thing we might see is some FOS changes. I don't think I have a slide on this, do I? No. So phosphorus can really get out of whack, so that's one we like to monitor. Usually people will see a really low phosphorus level as the cells all of a sudden like almost, I think of it like they're waking up from a slumber, right? Because they're all of a sudden ready to eat. Even though that's totally wrong physiologically. That's how I think about it in my head. But anyway, you have all these resources all of a sudden available, and so all these things might shift extracellular to intracellular as these processes and metabolic processes are getting ramped up and used again when they've been sort of dormant for a little while. So you end up with again shifts in electrolytes. Phosphorus is the biggest one we see. So you might see people who need really aggressive phosphorus replacement right away. But if you hear the term repeating syndrome, that's what that is. It's usually the biggest concern is that electrolyte shift. Occasionally you might see potassium shift too. You might see like a really K drop really suddenly. Of course, that could be replaced pretty easily, but it's something to watch out for. And that's why we do all that aggressive monitoring with repeating. Yeah.
Can this just be on a normal IV line, or does it have to be like a central line?
You can do both. The concentration depends on what you do. Usually we like to do them central lines because you can concentrate the formula more, so you have a lower volume overall. Because these are usually like anywhere from 1.5 to 2.5 liters of volume per TPN per day. So you can do a couple different strategies. There's peripheral, but it's usually going to be a much larger volume because you need less concentration to get all the volume through. Sometimes they do cyclic too, where they'll start off at a really low dose and ramp up to a really high rate, and then they can finish it off in a different time that way. I don't think there's any benefit to doing that, but yeah, we prefer central line if we can with these. Yep.
This might be silly, but like if someone's on TPN, will they still feel hungry or not?
That's a good question. I don't know. I would think they would. Yeah. I guess I've never asked that. Yeah. It's not really my patient population that I work with, so it's an interesting thought. Okay, and then finally, continuous renal replacement therapy. I just wanted to mention this very briefly. This is something we can do, and it's essentially like continuous dialysis for patients. And it's something that is a more or less last-ditch effort. It doesn't mean you're kind of on death's door when you're trying it, but you're pretty close. So it's not good. We'll put it that way. So CRT is not good. We usually have anywhere from like 3 to 6 people on it at a time at our hospital to give you an idea, and we have about 60 some ICU beds. So just to give you a picture of like the percentage of patients we see with this. So what this does is it limits rapid solute and fluid loss, and it gives you some more hemodynamic stability, which is great. The other thing we can use this for is removing immunomodulatory substances in septic patients. So where we like to do this a lot is with people who have influenza, and they also have a streptococcal pneumo, some sort of strep, or even staph comorbid pneumonia is what I'm trying to say. You end up with all these types of inflammatory substances in the body causing sepsis, and it's difficult to get that under control with antibiotics alone. Your presses are working overtime. You can actually remove some of these via filtration with CRRT. So it's just putting things through a big filter, and then you're giving a specific dialysate and then replacement fluid for the blood. So it's really just like dialysis. There's not much difference there, but it's just continuously going. It's going nonstop. So you go through tons of fluid. You're going through like liters and liters and liters and liters of fluid. But it's kind of an interesting process that changes a lot of your drug distribution and drug kinetics too. But at the same time, it's something that's necessary in these patients. So I'm not going to get into more detail than that because it's a very specific subset. But if you work critical care, you might see this. So I figured I'd just mention it. So, okay, let's just take a quick 5-minute break and we'll come back and finish up the last set of slides.